topic of my discussion is homografts in cardiac surgery. Look deep into the nature and then you will understand everything better. Albert Einstein. Next one. So heart valves are marvels of natural engineering. Most people last a lifetime. But when valves become diseased, they may need to be repaired or replaced. We use two kinds of valves. They are the mechanical valves and the bioprosthetic valves. The mechanical valves in today's time are not very popular because of the clot formation and the blocked heart valve, which proves fatal most of the time, particularly in countries like India and China, where the compliance of the patient regarding the anticoagulation therapy is very poor. The incidence of atrial prosthesis or the hemorrhages, particularly cerebral hemorrhages or the pulmonary hemorrhages, are very common and they are life-threatening. The bioprosthetic valve type or the tissue valve, we have xenograft tissue from different species like porcine valve from the porcs and bovine pericardial valve from the calves. Number two is the allograft or homograft. They are tissue from the same species. Here we are taking of the human valves collected from the human cadaver. Then the autograft is a tissue from same individuals like pulmonary valve removed from pulmonary position and is implanted in aortic position. Homograft of tissue from a donor of the same species as the recipient. Next one. Now, this is what the Dr. Donald Ross, who implanted the first homograft valve clinically in a human being, and it is his impression about the human tissue valve. He says although the homograft story goes back a number of years, it has progressively gathered strength and new eminence. I, for one, have never doubted its triumphant progress. Unlike man-made offerings, which come and go like the reasons the homograft was conceived, not on this earth, but in a celestial design center with not just several years, but millions of years of background and testing. This maker is unlikely to be bettered now or in the future. They simply says that the homograft valve is the best designed valve among all tissue valves available today. Now, this is about the story of the historical aspect of homograft valve. These are the pioneers who used these valves successfully clinically and made it very popular. Like we have the Lamb in 1962, 1952 is the Gordon Murray. Then we have in 1961 by Dr. Bigelow. 1962, the initial clinical use of aortic valve homograft was reported independently by Donald Ross of England and Sir Brian Barrett-Boyd of New Zealand. And it was Duran and Gunning who developed a technique in the laboratory for implanting the aortic homograft valve. So let's go for the uses of homografts. The homografts are very useful for inpatients, particularly in poor patients and in poor countries like India and China, and they have many beneficial aspects for them. Number one is the replacement of the aortic, pulmonary, mitral and tricuspid valves. They can be used for the replacement of these valves, replacement of the aortic root. They can be successfully used for the replacement or repair of cusp of the aortic, pulmonary, mitral and tricuspid valve, for Ross procedure in adult as well as in pediatrics, as a vascular pack material, and for congenital heart surgery, in tetralogy of Fallot with pulmonary atresia or other complicating factors. The other congenital heart surgery is truncus arteriosus, transposition complexes, double outlet right ventricle, and coaptation ripples. Now, this is what the pioneers in the homograft valve replacements, as we talked, the Sir Donald Ross in 1962, and the same year it was Sir Brian Barrett-Boyle of the Green Lane Hospital in Auckland. So now coming on the clinical aspect, worldwide, more than 3 lakhs of valve surgery replacements per year are being performed. And there is a growing biologic tissue valve segment. More and more patients are receiving the biological valve. They are more than 50%, and number is rising now. There is an increasing market, up 10 times in next 10 years, aging population, increasing world population, underdiagnosed patients in developing countries like India and China. So what is actually happening? The number of valve replacement, particularly with the tissue valve, is rising. And it is because the people are living for longer age, like aging population, the world population is increasing, and more underdiagnosed patients in developing countries like India and China are not being successfully diagnosed and operated. So as we see, the Asian market is changing rapidly, and next one please. In Asia in 2001, there was only 5.4% issue valve. Now in Asia, the number has grown up to 15.3%, and it is further rising. This is a mechanical valve. As you can see, the bileaflet valve is blocked because of the clot formation. Very fatal condition leads to sudden death of the patient. Next one, please. Now, as you can see, the high incidences of complication with the mechanical valve. There are high incidences of hemorrhage due to over-anticoagulation and high incidences of thromboembolism due to the under-anticoagulation. Now, this is what is seen that in patients who have the tissue valve, and if they are operated for reoperation, the risk linked to reoperation is much less. For example, in mechanical it was 20%, in the tissue valve it is 1.5%. The risk factors, now we see the warfarin and anticoagulant drug which is required for the management of the patients with the artificial mechanical heart valve, and very complicated drug. And this has a very risky drug because warfarin has a very narrow range of therapeutic range. Weekly to monthly testing, only 50% of time is actually spent within recommended INR, variable doses, and dietary constraints. So these make the warfarin very difficult to manage. Now, it is estimated that more than 50,000 homografts have been implanted worldwide till now, half of them between 1962 to 1974, not more than 1,500 between 1974 to 1985, due to competition posed by the extended Limbaugh valve. So it is easy to anticipate, however, that the born-again enthusiasm will decline again unless surgical indication for the use of homografts are properly set. Expectation about the long-term performance of these valves are based on reality. The existence of the inherent complex biological tissues are fully recognized. This is the statement of Donald Ross himself, who is the inventor of the homograft, and he said if you don't use these homografts carefully, apparently they will show the untoward results. Now this is the 10 Commandments, and still counting. These are the 10 Commandments for the successful use of any wall, and this is a wall must not propagate emboli. It must be clinically inert and not damage blood elements. It must offer no resistance to the physiological flowers. It must close promptly, less than 6.7. It must remain closed during the approximate place of candidate valve. It must, so like this, these are the 10 commandments requisite. And when you see here, the most of these are fulfilled by the homograft, while some of these are fulfilled by stented, the heterograft, and mechanical prosthesis. So you see, mechanical prosthesis is very poor on this scale of 10 commandments, while homograft valve is the best, and it satisfies most of these 10 commandments. Now, what are the criteria? Let's go back if you can. Okay. So this is a homograft, as you can see, and the top you can see or stented valve, and then you can see the flow through the bioprosthetic valve, which is the turbulent, while bileaflet valve is a very turbulent flow. So bioprosthetic valve flow is definitely much better than the mechanical valve. Next one. So the criteria used prior to collection of homograft, this is we are just talking about how to establish a homograft valve bank in your center. This can be easily established even at a smaller center, and would just need the freezing, or what you call the cryopreserved valve in every center. If you can have antibiotic sterilized valve, which is present in the refrigerator in a preserving solution like plasma or into the HIV solution, so we can easily perform these operations. These are the criteria. Donor should be less than 55 years, donor should have no infection, collection should be less than 24 hours, no evidence of HIV, HPV, HCV, or syphilis, person who has received an organ and tissue transplant should be avoided, hemophiliacs who have received human-derived clotting factors. So this is what we see non-beating heart donors usually before the postmortem. So these are the homograft valve donors, beating heart donors in an operating theater. These are the patients who are brain dead patients, or non-beating heart donors from a clean mortuary, beating heart donors, multi-organ donors. These are all the cadaver patients who are brain dead but on ventilator, heart transplant recipients. They are non-beating heart donors usually before the postmortem. So these are the two major sources of the homograft valve. Next one. So what are the techniques of sterilization? This is briefly we can see mainly two alternatives are applied for the preservation of these valves. Number one is cryopreservation in a vapor phase of liquid nitrogen. This is something which demands a huge setup and a lot of money, but then you can store the valve for a very long time. Number two is a fresh wet storage at 4 degrees centigrade after antibiotic sterilization. This any center can develop at their hospital. This doesn't involve much of the money involved, much of equipments are not involved, and these can be usually used for 3 to 2 weeks after selection. Now this is what is the technique, how to harvest the homograft. You can see the heart is removed along with the aorta, and then it is put for dissection in a lamellar flow dissector, and we remove the wall from the heart along with a piece of aorta. And then after removing, it is rinsed very well, and all the samples are taken for HIV, HCV, and HBsG, tribunema, pyridum, and blood group. The allograft is dissected in antiseptic technique. After dissection, it is washed in the hand solution, and then it is put in antibiotic containing solution for 72 hours. So this is how we can harvest the valve and how can we put into the now this is showing the homograft valve bank. As you can see here, these are the two cryo-freezing techniques, and there are two bags who have cryo-freezing, and the nitrogen cylinder is also been put here. Now in our D.K.Satsangi hospital, which I was working earlier, and the last 30 years we have performed next one please, a number of homograft valve replacement. Now as you can see, there were 75 patients for AVR, and they had a satisfactory early late result, and this is ideal for the Indian patients. Let me have the next. So this is our patient, and about the 75 patients, they showed good results. Then we have got homograft aortic valve replacement using a stellar technique, as it is being shown here. 55 patients were operated. Early mortality was there in 2 patients, late mortality for 2 patients. There were good long-term results, so we found it very satisfactory to use in poor patients in our hospital. Yes, give us this. Now this is homograft aortic valve root replacement, which we use in a Bentall procedure. We had 20 patients. Early mortality was in 1 patient, late death in 2 patients. Long-term results were very good, and we are very satisfied using this valve conduit, homograft valve conduit, for the aortic replacement in patients with aortic aneurysm with the aortic valve involvement. So 1964 to 2018, we were using these techniques. So various studies confirming good long-term results of antibiotic sterilized homografts. I will say one series from the Magdi Yaqub in 1986 from Harefield Hospital, London. They show that the freedom from valve failure of 92% over a period of 8 years, which is very, very satisfying. And then we have the Jacovac in 1986, aortic root replacement using antibiotic sterilized pressure centered homograft. And he shows that 43 patients with antibiotic sterilized homograft in repair of aortic aneurysm of ascending aorta. And with a fresh unstenotic valve, and they showed a very good results. Third is the J.K. Ross. J.K. Ross is the pioneer in replacing the aortic valve, 11 years results, and he shows the follow 90% freedom from reoperation of 5 years. These results are far better than any series using the mechanical valve or the bioprosthetic valve. Magdi Yaqub again in 1986. He reported 10 years experience with aortic valve replacement using antibiotic sterilized homograft. So this is now after this results we can homograft mitral valve replacement. You can see mitral valve, which is a size from the donors, and this is here we use a mitral valve ring, which is this valve is mounted on that. You can see the papillary muscles down, and then we implant the papillary muscle, and then we using the ring, we implanted the homograft valve in 2 patients. The one patient had led death, but later on, because of this experience, we did not do many of the mitral valve replacement, as the experience of other people also with mitral valve homograft valve replacement is not very encouraging. Let me have the next slide. Now, this is what we talk of the autograft, or the procedure, or what we also call as the Ross procedure. In Ross procedure, you remove the pulmonary valve and then you implant it to aortic position, and then you take a aortic homograft, and with which you reconstruct the right ventricular outflow tract and reconstruct. And this is how the Ross procedure is performed. The results of Ross procedure is wonderfully much better than homograft valve alone. But the only problem is that it's very complicated operation, as you are replacing 2 valves, takes a long time also. So this could not become very popular. But for in patients, but in patients who are pediatric, this has a very good result. Last 22 years, we performed about 46 Ross procedures. Last 4 cases, homograft was not available. We used Contegra for the reconstruction of the right ventricular outflow tract. Age was from 12 to 35 years. The predominant reason was the aortic regurgitation as complete. So the results that we see in the Ross procedures, we did not have much complications. There was only 2 operative deaths. Both patients had aortic root abscesses undetected in 3 of echo. Freedom from thromboembolic episode was 98%. Freedom from endocarditis was 99%. All patients were in NYHA1 and 2. So excellent results we could produce with the Ross procedure. So now this is about the pulmonary autograft or the Ross procedure. These are the various series like LHELIS. LHELIS is a very long series of about 60 patients, and then there was a series by the Ross himself, and his results in 78 cases were very encouraging, and these patients operated after 26 months. This is our technique, what we developed at Deakin Hospital. This is what you see is the pulmonary valve autograft, which is received from the patient, is mounted on a stent, and you can see here, and this is implanted in a mitral position. We perform the 5 patients without any failure, and all patients are doing well. So it's a modified last 2 procedure for mitral valve replacement with pulmonary autograft. So in summary, we have key points, and mechanical valve still represents a significant portion of the valve replacement market. All mechanical valves require lifelong anticoagulation, and warfarin is their only option. Warfarin is one of the most difficult drugs to manage, and its risks and drawbacks increase dramatically as the patient ages. The guidelines have learned in favor of the tissue valve. So we see the tissue valve replacements are becoming more and more popular. Thank you very much. Thank you very much.